Chapter 21. Assessing the older adult. When assessing the older adult, we need to keep in mind sometimes there's deficits in vision, hearing, and we want to use clear, simple language while facing the patient. We also want to use strategies such as reducing environmental noise, helping them to focus. High blood pressure, pain, urinary continence, and memory loss are not normal parts of aging, but are symptoms that commonly occur in this demographic. They may also underreport pain due to a fear of treatment or thinking that it's normal. When looking at the head, ears, eyes, nose, and throat, tearing is a diminished resulting in dry eyes, which causes irritation and discomfort. Corneal sensitivity often is diminished as well, so that older adults may be unaware of infections or injuries. As the lens becomes more rigid, usually by age 45, the ciliary muscle of the iris weakens to the point of accommodation changes and difficulties. Color perception is also altered, with difficulty seeing especially colors of blue, violet, and green. There's also a decrease in active sebaceous glands, causing cerumen to become dry and may completely obstruct the external auditory canal, also resulting in diminished hearing. That increased cerumen production is also going to be a normal factor that you'll see in aging, and also some test question you'll see come up in ATI a bit as well. Excessive deposits of bone cells may begin to accumulate within the ear that can cause a deterioration in hearing. In the case of sensory neural hearing loss, also develops as the hair cells begin to degenerate. This usually starts occurring around the age of 50. Also, it tends to be the higher frequency pitch tones that go first. A decreased sense of smell caused by a decrease in the number of sensory cells within the nasal lining. The gingival tissue becomes less elastic and more vulnerable to injury. Because of gingival recession, root surfaces of the teeth are also exposed to caries and cavity formation. The tooth enamel tends to become harder, though more brittle. And as teeth lose their translucency, they darken and become worn from use. The tongue becomes more fissured. Altered motion function of the tongue may also lead to swallowing problems, which is a big safety risk. I know we've touched on a bit already of the dangers that dysphagia and aspiration pneumonia can pose to the elderly. Kyphoscoliosis. Remember back from our musculoskeletal module of kyphosis being that exaggerated curvature of the thoracic spine, whereas scoliosis is going to be a lateral curvature of the thoracic spine. When looking at the respiratory system, as alveoli become less elastic and more fibrous, dyspnea on exertion can become more frequent. There are fewer cilia to clear the mucus and contaminants that enter the lungs. Also, the mucous membranes become drier, and the person's less able to clear that retained mucus. The heart size also tends to decrease, with a response to stress or increased oxygen demand being less efficient, and a return to baseline heart rate can take longer. Cardiac function is also affected by fibrosis and sclerosis. Within the musculoskeletal system, a decrease in bone mass increases the risk for stress fractures. Intervertebral discs begin to lose water, causing a narrowing of disc space and resulting in a loss of height. The height may decrease as much as 6 inches or more from ages 25 to 80. Increased flexion of the back changes posture to a more flexed position, which in turn shifts the center of gravity. Also, the tendons and muscles tend to decrease in elasticity and tone, with muscles losing both mass as well as strength. Within the neurologic system, functional changes in sensory and motor function, memory, cognition occur at different rates. The short term memory, such as for names and recall of recent events, may decline with age, but long term memory usually is maintained. This is where our mental status examination comes into play, and I've also attached a copy of an MSc down below within the LMS as well. Looking within the female genitourinary system, after menopause, the labia and clitoris tend to become smaller and paler, while the epithelial layers become thinner and flatter. losing their subcutaneous fat as a result of decreased estrogen. In some women, ligaments and connective tissue of the pelvis may also lose their muscle tone and elasticity. The uterus and ovaries decrease in size while ovarian follicles gradually disappear. Hyperplasia is a major change in the prostate associated with aging. If prostate enlargement is excessive, a decrease or obstruction of urinary flow can occur. When looking at vital signs and baseline measurements, height decreases in most older adults due to decreased bone formation caused by a shortening of the vertebrae and thinning of the vertebral discs. The decreases in height may occur more in women because of osteoporosis. And for those in their 80s and older, body weight may decrease because of muscle wasting or chronic diseases. As skin thins, it takes on a parchment like appearance, especially over bony prominences, dorsal surfaces of the hands and feet, forearms, and lower legs. The skin hangs loosely on the frame, secondary to a loss of adipose tissue and a loss of elasticity. The skin may become cool due to impaired circulation, while edema may indicate fluid retention from cardiovascular or renal diseases. Additionally, prolonged exposure to the sun may cause the skin to take on a thickened, ruddy appearance. Other disorders of the skin is solar lentigo, liver spots. These are irregularly shaped, flat, deeply pigmented macules that may appear on the body surface areas from a repeated exposure to the sun. Other abnormalities are seborrheic keratoses, which are pigmented, raised, warty appearing lesions. You can differentiate these benign lesions from similar appearing actinic keratoses. And remember from back in previous modules when we talked about our acronym of assessing these abnormal moles and growths, A, B, C, D, E. We want to look for any asymmetry, any irregular borders, any color changes, any evolution. Is that lesion evolving? Is the diameter less than 6 millimeters? Skin tags are a small, soft tag of skin that generally appears on the neck and upper chest. These tags may or may not be pigmented. In the case of sebaceous hyperplasia, these are yellowish, flattened papules that have a central depression. Another normal part of aging is the hair becomes thin, gray, and coarse in texture. Symmetric balding may also occur in men, and I'm feeling a little attacked in this module. Men have an increase in the amount and coarseness of nasal and eyebrow hair, while women may develop coarse facial hair. The nails also may become thick and brittle, especially within the toenails. When looking at the neck, a stiff neck in the older adult may indicate cervical arthritis. In the case of vision, eyebrows may be thin along the outer edge, as well as the remaining brow hair that may appear coarse. Orbital fat may have decreased so that the eyes appear sunken or may herniate, causing a bulging in the lower lid or inner third of the upper lid. Brown spots may appear near the limbus as normal variation. The bulbar conjunctiva may appear dry, clear, or in light pink without discharge or lesions. A corneal becomes transparent, clear, often yellow. In the case of Archinus silenilis, this is common but not associated with any pathologic condition. Abnormal findings again include the lower lid drops away from the globe, or in which the lower lid turns inward. Central and peripheral vision may also be decreased after age 70. An acuity of 20/20 or 20/30 with corrective lenses is common, though accommodation can take longer. Color perception of blue, violet, and green may also be impaired. Gradual loss of central vision may be caused by macular degeneration due to changes in the retina. Cataracts are cloudy, opaque areas over the lens of one eye. During an ophthalmic examination, retinal structures usually appear dull with pale blood vessels. Arterioles may display a narrower light reflex and are straighter. Glaucoma, on the other hand, is an increased pressure within the eyeball that can result in a loss of peripheral vision as an early symptom. This is not to be confused with macular degeneration, which is macules that form on that back retina and can actually have distorted spots forming within the eye and a loss of central vision. In the eyes and vision, more crossing defects are also seen, with benign degenerative hyaline deposits that can be noted on a retinal surface, but don't necessarily interfere with the vision. If a patient wears a hearing device, the ear should be carefully examined and assessed for any skin irritation or sores. The tympanic membrane may appear whiter, opaque, and thickened. This also results in an increased likelihood of cerumen impaction, and this is going to be an expected finding. Again, remember, increased production of cerumen is going to be a normal part of aging. Presbycusis. This is our normal age related hearing loss. And again, it tends to be the higher frequency sounds that diminish first, making higher pitched sounds, especially in the case of some females trying to bring the tone of the voice to a lower tone may help them to be better understood by someone hard of hearing. The lips may appear dry, wrinkled, or have fissures. Older patients are also at higher risk of squamous cell carcinomas of the lip, especially if the patient has been a longtime pipe smoker. Aging also causes the gum line to recede. The gums may become more friable and bleed with slight pressure. Additionally, the teeth may become dark understained. Many older adults tend to become edentulous or have caps or bridges. Dental occlusion surfaces may also be markedly worn down. Malocclusion of the teeth may also be common, secondary to migration of teeth after a tooth extraction. A red edematous tongue with erosions in the corners of the mouth may also indicate iron deficiency anemia. Within the respiratory system, the thorax and scapulae should be symmetrical. Again, we're looking at those structural deformities that may be interfering with their respiratory system, kyphosis and scoliosis especially. Occasional ectopic beats are common and may or may not be significant. An S4 heart sound is common in older adults, and again, it's associated with decreased left ventricular compliance. Carotid bruits may be heard, indicating arteriosclerosis, with cold feet and weak pedal pulses due to decreased peripheral arterial disease that may be noted. Within the GI system, older adults may have increased fat deposits over the abdominal area, even with decreased subcutaneous fat over the extremities. The abdomen may also feel soft due to decreased abdominal muscle tone, making palpation of the organs easier. Muscle mass may be decreased as well compared with that in younger adults. Muscles that are not equal bilaterally may indicate muscle atrophy. Common findings include osteoarthritis changes within the joints, which may result in decreased range of motion. Many joints also may not have the expected degree of movement or range of motion as seen in younger adults. The mental status is assessed when taking the patient's history, conversing with the patient. There's a lot of information we can be gathering, additionally to the questions we're explicitly asking. The cranial nerves can also be accessed during examination of the head, eyes, ears, nose, and throat. And again, we talk about all 12 of those cranial nerves in chapter 15 at the beginning of this module. In the case of female reproductive system and the perineum, again, the labia and clitoris of older women are going to be smaller, paler. Pubic hair may be sparse, patchy, or absent. And the nurse may find that the vagina is narrower and shorter, with an absence of rugation in the vaginal wall. The cervix may also appear smaller and paler. This is going to be especially pertinent in advanced practice assessments. Findings for older adult men are the same as those for other adult men, though when we talk about elderly men, it usually comes back to that prostate. But BPH, benign prostate hyperplasia, is going to be a very common abnormal finding. Urinary incontinence occurs when the patient's unable to control urination, associated with relaxation of the bladder, urinary sphincter, or both. Risk factors include multiple pregnancies, abdominal wall weakness, obesity, urinary tract infections, cerebrovascular accidents, or multiple sclerosis. And for our last slide, urinary incontinence. Patient may report feelings of an immediate urge to void, urge incontinence, leaking urine when laughing, coughing, sneezing. This is stress incontinence. Also going to be very common post pregnancy. You're going to, I've no doubt, learn more about this in your OB module as well. You could also have issues ranging from continuous leakage of urine to leakage of urine during sleep. But anyway, that's all we got for this chapter. I'll see you in the next slides.